Okay, I think I'll get started. Thank you for coming. I gave this talk in December of 2015, 10 months ago, and I've changed it. There's exciting things that are happening in our fatty liver clinic. There's a handout in the back. I see some of you have it already, if you'd like to know more about what we're doing. And so today's talk will be some more basic information, just so that we get the epidemiology and natural history of non-alcoholic fatty liver disease, but I made a point to try to put some things in here that are new, I think exciting and relevant for our patients. I don't have any disclosures to report. This was a summary of an article, I believe, in Hepatology recently, which I'm including in this talk because I think it shows a few things. It's the first map. There's a lot of maps in this talk. This is the first map that I've seen of fatty liver disease, and diabetes and obesity have been tracked very closely by the CDC now for some time. So in this map, you can see the worldwide prevalence of non-alcoholic fatty liver disease, and you can see some things that you probably knew and maybe some things that are surprising. For example, we've known for a while that the prevalence of NAFLD in the United States is in the 20-25% range. So this was estimated at 24.1%. You can see that in South America, the prevalence is higher. And if you think about the patients that we see, that's not surprising to me either. But the things that you also see are that the prevalence is higher in Asia, which we have been learning, and the highest in the Middle East, which is something that's been true for a while but has really been shown or proven, I'd say, just in the last few years. The other thing about this chart that I like is that it estimates, and it's difficult to estimate this, but it estimates the average daily energy availability per capita. In other words, how many calories are available to us. And you can see that the United States is one of, I think it's the reddest country there. And we have available to us, if you ate everything that you wanted to and then more, over 3,600 calories a day, which is an immense number of calories. And unfortunately, that's actually what a lot of people are eating. So this is a nice update here. Yeah.
So is the increase in Asia and Middle East, is that just like they're diagnosing it more because they are aware of it? Is it because they're getting more obese?
It's definitely because they're more obese. It's also because there's probably a genetic predisposition. And it's probably also because some of the studies probably weren't done until a few years after. I mean, I think a lot of the real epidemiologic studies were done here first, Europe, then Asia, maybe the Middle East. But you know, the obesity epidemic in the Middle East is not new. I mean, the spread of the Western lifestyle and all the things that cause fatty liver disease have been all over the world now for almost 20 years. So I think we're just getting better data now. So I think it's all a little bit of everything that you said. So why is there fatty liver disease? Well, the answer is there's an obesity and a metabolic syndrome epidemic. This was the cover of The Economist now 13 years ago. And you see that the most evolved human here is holding a big gulp. And so I'll get into that in just a minute. The Economist actually has a few pretty well done pieces on obesity and the worldwide obesity epidemic. So this is one that I had not seen before, so I included it in this talk. This is a world map, just like the one you saw, that shows overweight as a percentage of the entire population of that country. And so here you see that we're talking about overweight. This is a BMI of 25 and above. So there are countries, including ours, where the prevalence of overweight is between 60 and 70%. And there is one country where it's above 70%. This is 2008. And that country is Saudi Arabia. And so that just sort of speaks again to the idea that this is a worldwide epidemic and that there are places in the world where the numbers look a little worse than the U.S. That has to do probably with the certain genetic profiles of the people who are eating the same diet that we eat. And I think the effects are probably a little bit different in those populations. For example, Asia, we know that the prevalence of the PNPLA3 gene is higher in Asians. We know that the distribution of body fat is higher in Asians. And we know that the cutoff for overweight is 23 in Asians, not 25. So if you look here at Asia, which has an 11% increase in prevalence of overweight between 1980 and 2008, you have to ask yourself, well, what color would China, Japan, Korea, Philippines be if they actually use the right cutoff for overweight? And so I would imagine they'd be pinker or even oranger than they are right there. So one of the things that, there's a number of reasons why we have this epidemic. It has to do with how easy it is to process foods in the last 40 years, how good we are at storing food, advertising, I mean, all sorts of very, very interesting social things. But one of the things that is the leading cause of added sugar is sugar-sweetened beverages. This has been shown time and again. And it turns out that sugar-sweetened beverages have quite a bit to do with fatty liver disease as well, in particular fructose, high fructose corn syrup. So I'll spend a minute talking about that because it's timely now that it's October 24th of this year. So in the Dust Bowl in the 20s, in the Great Depression, we had dangerous food shortages. And so the government got into the habit of subsidizing crops so that we wouldn't starve. And that was a required and necessary intervention back then. Those subsidies, farmers came to rely on those subsidies. And I think the reason that we have these subsidies now is that our cost of living, cost of functioning, cost of doing business, and cost of farming is so high that these farmers, it's not a level playing field. They can't sell our corn on the world market and be at a competitive price. So we still have subsidies. We subsidize the farming industry between $10 and $30 billion every year. And I looked this up, for the last few years, corn specifically has been subsidized between $2 and $4 billion per year. So that's a lot of money going into the corn industry. And as a result, we've maintained a very productive farming industry, and we have a lot of corn. So in the 60s, we learned how to make high fructose corn syrup. That was sort of, food science and agriculture science. that was coming. High fructose corn syrup is usually 55% fructose, 45% glucose, and sucrose, as you know, is 50-50. So the big event I think that's relevant is that in 1976, the FDA approved high fructose corn syrup as a sweetener or a preservative for foods. And as I'll show you, I think we see that within a decade, you start to see the birth and the rise of the obesity epidemic, and close on its heels, the coining of the term NASH and NAFLD in 1980, and then the epidemic that we have now, such that fatty liver disease is the most common reason to be on the liver transplant list and the second most common reason for liver transplant. And just to show you some of the studies that have been done with regard to fructose. So this study took, I think, 12 healthy volunteers, average age 28, half men, half women, and they gave them a big slug of carbohydrate, 85 grams of sugar, which is a lot. That's 2 Cokes all at once. And 4 hours later, they ate a lunch. They had blood draws at every hour there, maybe even every 30 minutes, and they measured de novo lipogenesis. They measured a lot of things. I'm just including the de novo lipogenesis slide. De novo lipogenesis is probably the most closely linked to fatty liver. It's those free fatty acids that are made in de novo lipogenesis that accumulate in the liver, cause fatty liver disease, and are associated with triglycerides, VLDL, and diabetes. So you can see that the black circles here, that's all glucose, no fructose. Contrast that with the other 2 shapes, which is either 50% fructose or 75% fructose, and you can see that just the presence of fructose leads to a doubling of your de novo lipogenesis. And so you can kind of see that fructose really turns this on, whereas glucose does not. And so it's with that in mind that a lot of people who are concerned about health have really created this movement where we're trying to be more aware of high fructose corn syrup, and nowhere is that more relevant than in the Bay Area in 3 weeks. So in 2014, Berkeley put forth and passed Measure D, which was a 1 cent per ounce tax on sugar-sweetened beverages. And this year, San Francisco with Measure V, Oakland with Measure HH, and Albany, small Albany in the East Bay with Measure O1, have similar proposals. So I tell you this because an interesting article came out recently that suggested, it's the first one, so it suggested that this bill, specifically the Berkeley bill, has changed behaviors in the way it was intended to. Obviously, it needs to be reproduced because some of these findings are perhaps more impressive than they thought, but still very interesting. So they polled people from low-income neighborhoods immediately after, 8 months after the vote, but before the implementation, and then 4 months after the implementation, and they said, did the change in the price of the beverage change your behavior? And it did, with less sugar-sweetened beverage consumption in Berkeley versus Oakland and San Francisco, and more water consumption. So it does seem that high fructose corn syrup is related to fatty liver disease. It does seem that some of these measures, it does seem that these things are relevant politically, and certainly it looks like it might be helping as well. So let's go back to what I was saying about it was in the 80s that we started to see the increase in obesity in this country. I skipped the 80s because there's a lot of missing data on these CDC maps. But you can see here in 1990 where we have almost all the states reporting data that no one had a prevalence of obesity greater than 15%. And I'll just go through these quickly so you can see what happens to the country over these 20 years until we get to 2010, where there are, 10 or 11 states with an obesity prevalence greater than 30%. Now, we have the next 6 years now, or 5 years, and they had to change the map because we had to include a category of obesity prevalence greater than 35%. And that is now seen in a few states here in the Gulf South. I will include this last map. I like maps. So the last map here shows you on the top what I just showed you with obesity, but then we're starting to get better data on diabetes. And so you can see that the prevalence of diabetes, which was never above 5.9%, at least not self-reported in any state in 1994, is now above 9% in more than half the states in the country. So it's a real problem. Diabetes and fatty liver are the two most closely linked parts of the metabolic syndrome. So it's a very relevant talk. But what about the prevalence of fatty liver in the United States? So we know about this data. This is the closest we have to a map, but we have some data. So what if you have 100 people, 100 livers? How many people have fatty liver? Well, I showed you that already. It was 25%. So there's your 25 livers. Fatty liver is everything. It's simple steatosis, as we used to call it, which would be, pink hepatocytes, white fat droplets, and really no blue cells at all. No fibrosis either. But it also encompasses NASH, NASH with fibrosis, NASH-related cirrhosis, and worse. So that's all-encompassing. In our fatty liver clinic, though, we're asking a more specific question. If you have 100 patients with fatty liver, and we do, how many of those have NASH? So the answer there turns out to be 20%. So that means two things. One, there's 60 million people with fatty liver disease, and a fifth of that is still 12 million. That's a lot of people with NASH. But two, it means that you really do have to tell the patient when you meet them that we'll do the evaluation, but that NASH is, the percentage of people who don't have NASH is high. There are many people with fatty liver who don't need to see the hepatologist. There's many people with fatty liver who should talk to their primary care physician, talk to their endocrinologist, and not see us because 80% of them shouldn't be seeing us. And I think that's what we're trying to get at in our clinic with our FibroScan, with the new CAP function. I think that's going to be very useful in saying, which of these patients can we just say right off the bat, don't come here, spend your efforts with your endocrinologist working on your diabetes and your weight loss because you don't have risk factors for progressive chronic liver disease. This would be NASH. Now you see the blue cells. They're supposed to be neutrophils, but you can also have lymphocytes, usually surrounding the fat, usually in little clusters. And here's a reasonable example of ballooning degeneration. This would be a little bit here. Things just look like they're breaking apart, maybe here as well. But what we really want to know is who among those with NASH has fibrosis. And so the answer there is a lot. Half of the people who have NASH are going to have fibrosis. And we're still talking 2 to 4 million people in the country. So it's a very prevalent disease. Remember, these are all silent conditions, and I'll show you a slide in a minute that suggests that, especially in patients with diabetes, all these conditions can have a normal ALT. So it gets really tricky trying to find these patients. You have to sort of say, well, who's at risk, and should I just screen them anyway? Because you're going to miss some if you just look for that ALT of 80 or 90. This would be NASH with fibrosis. Yeah,
Sorry.
that's okay.
Is it 50% because it's active inflammation? So as soon as you have NASH, you're kind of...
I mean, I think what we know about this disease and many others is that so many people progress at different rates that some people are going to get stage 2, immediately and not progress. Some people will go 1, 2, 3, 4 in the way that we sort of linearly think about it. And some people will have NASH their whole lives and never progress. And there's data on that. In general, I tell patients, and I think it's reasonable, that if we find you with NASH, especially if they're a little bit older, with NASH and no fibrosis, that their chances of progressing outside of our data, they should progress at one stage every 5 to 7 years. There are a lot of diseases where the state that you find it is often, they've probably been there for a while. 40% doesn't progress, 20% regresses. So not everyone marches down the path. I don't know, did that answer your question, Mona?
And is there a genetic sort of...
Only the one that I talked about, yeah. There's a couple others I won't talk about.
And that statistic that you just gave of one stage every 7 years is for patients who don't intervene.
It's correct. I'll show that slide. That's for patients who had some fibrosis already. It's slower if you have the first steatosis slide that I showed. Those patients are thought to progress slower, which is like a 1 every 14 years. And so that really gets at the point that when you first evaluate the patients, that first evaluation, it probably means the most. Because the progression of the disease is slow. It's 1 grade every 7 years is the same that we think about Hep C and Hep B and things like that. And then the last question is, if you have this breakdown of NAFLD, NASH with fibrosis, how many of your 100 patients with fatty liver will have cirrhosis? And the answer is 1 to 2 out of 100. And more than half of them don't know they have it. So the reason I've shown you this is that the numbers are very high. The number of patients who are in trouble it's a low percentage. But if you look down here, 1% of 25% of the population is over 500,000 adults who have NASH-related cirrhosis. So the mortality seen associated with fatty liver disease is only seen with stage 3 and 4 fibrosis. But the problem is we know the mortality with cirrhosis, and this is a large population. Here's a slide that will help you sort of put it into context. So I tried to put in this slide diseases that are relevant either for this talk or for us as a group, a liver group. So the prevalence of obesity, if you count, is probably 240 million American adults, give or take, and 1/3 of them are obese, and so that's 80 million obese American adults. That's pretty close to the number of adults who have fatty liver disease. And in fact, I kind of lowballed it. There are some studies that would say that the number of patients with fatty liver disease is 80 million. How about patients with diabetes in the country? It's almost 30 million adults. That number was higher than I thought before I put together this slide, but that was, there's multiple references there, including the CDC. But, I wanted to put it into context. We do see quite a bit of alcoholic liver disease. And so how common is that? How common is excessive alcohol use? The most reliable number I found was actually using the DSM-4. Alcohol use disorder is estimated to exist in 16 million Americans. More of those people will get cirrhosis than those with NAFLD, 10%. So 10% of 16 million is 1.6 Americans. This is an estimate, obviously. It's hard to count these patients. But again, I think if you look at how close these numbers are, I think this is going to be the right ballpark. 1.6 million American adults with alcoholic cirrhosis. If you go back up, I already showed you that about 12 million people have NASH. We know from quite a few epidemiologic studies that the prevalence of Hep C is about 4 million. 3.5 is quoted, but when you count people who aren't easily documented in some of these studies, you get close to 4 million. Hepatitis B is lower in the US, but much higher in the rest of the world, just over 1 million. And then HCV cirrhosis, NASH cirrhosis, those are going to be in the 600,000 to 800,000 range. Compare that to your cholestatic liver diseases. Kiddis, I would love to know if you think that these are off, but I looked in a few places. They report things like point prevalence per 100,000, and I was seeing numbers between 1 and 40. So if you do the math, this should be the right ballpark. Do you think it's off by a significant amount?
I would say, close. CPMC might be a bit more.
Okay, yeah. But I think the point I wanted to make was that you're basically an order of magnitude less than some of our other diseases. So this, John, this is these are the paired biopsy studies. So these were done, I think they're both done in England. Studies that look retrospectively at paired biopsies in NASH patients who didn't have any bariatric surgeries or vitamin E or any treatment for NASH, just to look at the natural history of the disease. Those who had no fibrosis at the beginning progressed very slowly, one stage every 14 years. Those who had NASH with fibrosis progressed faster, one stage every 7 years. The take-home point here is twofold. One, you can still progress without fibrosis, so you can't really tell patients they're good for the rest of their life. You just have to tell them they're good for some time, and they should focus on non-liver-related diseases like diabetes and obesity. And two, it's a slow disease. So there's always time to postpone a biopsy by a year or two if that's what the patient prefers, and that's what we do in our clinic. Up at the top here, this is the data I was talking about on those who progress. 42% progress, 40% are stable, 18% were found to regress. So you can't, you have to be careful when you are telling a patient that they are going to progress. We don't know that they are going to progress. We can tell them if they're likely to progress based on risk factors, but not everyone does. And I mentioned this a little bit as well. Fatty liver alone is associated with the development of type 2 diabetes, and fatty liver alone has an odds ratio of almost 3 in this study of developing diabetes. Interestingly, obesity without any other metabolic syndrome components was not associated with the development of diabetes. You have to be careful when you say metabolically healthy obese. You have to really ensure that they don't have hypertension, dyslipidemia, fatty liver, other things. But if they do have that, there does seem to be a group of obese patients who are not at risk. And likewise, we do find some obese patients who don't have fatty liver disease. It's a minority, but there are some. Both obesity and fatty liver is a huge risk for diabetes, and then you ask what their family history is, and that number probably goes up even higher. There's been 2 big studies that show that NASH is associated with an increase in mortality. Both studies showed it was only advanced fibrosis, and in both studies it was not liver-related mortality. It was still cardiovascular and cerebrovascular mortality. So again, that just drives home the point that cirrhosis from liver disease is rare if you look at it as from NASH, is rare if you look at it as a percentage of all those who have NASH. But I think that fatty liver is relevant even outside the liver. All right, so I'm going to talk now about. I just showed you that. I tried to show you that NASH is relevant. It not only in the liver but outside the liver. That it's very prevalent, and I've mentioned that it's hard to find. So how do we find these patients who are at risk? How do we, if we could be granted one wish, would it be to have all the patients with NAFLD come into our clinic? No, it's 60 million people, and we need to be a little more efficient than that. So we have some non-invasive scores. This is the one that I use, but there's a FIB4, there's an APRI score. These are all calculators either on your phone or online. And this one's the NAFLD fibrosis score, and I like this one because all the variables, well, first of all, I like it because there's a nice app. But second of all, I like it because all the variables that are in it are relevant both for metabolic syndrome and fatty liver disease and for liver disease in general. You'll find that if you see patients with liver disease, you've already thought of all these things before you type in the score, and you're almost never surprised by the actual score. It's useful for documentation and comparison. It's useful for people, for example, when I speak to endocrinologists, they'll download this app, who don't think about, is the albumin 3.6, is that really normal? Or is the platelets are 149, is that really normal? Most people who don't see a lot of liver disease aren't thinking that way, and they may not be able to guess as well. But age, BMI, diabetes, AST, ALT, and the ratio in particular, platelets and albumin, and these things give you the scale that's not that user-friendly. Negative 1.455 is the low cutoff, and 0.675 is the high cutoff. And in the middle, you can't be as sure. But the good news is that if you do fall into the high category or the low category, the positive predictive values or the negative predictive values are actually quite high. It's just what do you do when they are indeterminate? And many are. If you look at these variables, if you're over the age of 60 with diabetes, you're going to be indeterminate right there. So the test is useful in some situations, but it can't be the only thing that we use. But just to give you a sense of how it could be used, here's a patient, 43, Caucasian, overweight, obese. If you use the A1C, she's not diabetic, triglycerides are not high, and she's not a drinker, and the enzymes are, an ALT of 28 is pretty minimally elevated, and everything else is normal. She has fatty liver disease, she has fatty liver on ultrasound, and I've had the question, I've shown this before, someone asked why did she even have the ultrasound? The answer was she was in the ER with abdominal pain. So she had the ultrasound, was referred to me, and I showed that her risk of having advanced fibrosis is low. And then you just step back and you look at the patient and you'd say, well, it would be kind of surprising if she had advanced fibrosis from NASH. She's young, she's not diabetic, she doesn't have those risk factors. So what would we do for her? I wouldn't biopsy her, I wouldn't see her in clinic if I had the opportunity to do so ahead of time, to sort of head that off at the pass ahead of time. It would be lifestyle modification and maybe recheck 2 to 5 years, something like that. I think that would be appropriate for this patient. Yeah, it's okay. You're supposed to ask a question.
Does the ALT of 28, is that in any way, would you recommend lifestyle modifications just based on that ultrasound, or do you look
Based on the
at
ultrasound alone.
Okay.
Yeah.
So the ALT
And she's obese, so it's likely that it's true.
Right, and her ALT is a little bit higher.
Yeah, so I don't know if you're asking would I send an autoimmune workup and iron. So this, if you send that on everyone with an ALT of 29, I don't think you can do that. So I think in this context where the question is, does she have fatty liver and does she have risk factors for fibrosis? No. If the question is something different, there might be a circumstance for, but it's not normal, but it's pretty low. You got to be careful with statements like that. FibroScan is the thing that I'm combining with NAFLD fibrosis score to get pretty good risk estimation. Again, there's always going to be a group in the middle where you can't use non-invasive tests. But I think the combination of these two are getting pretty good, at least in saying that person has something and that person doesn't. So this is the algorithm. You take patients, and in particular you would take someone at the high-risk group. The prevalence of NASH with fibrosis in diabetics is 5 to 10%. So that's a high-risk group. I mean, we screen patients for liver cancer if they have an annual risk of 1.5%. So we're talking, this is, as far as, is a screening test cost-effective? Yes, a screening test is cost-effective in this group. So I do the NAFLD fibrosis score and the FibroScan, and it's been shown that if they're both low, multiple studies have been done with a negative predictive value between 93 and 99. That's very, very high. And so you're going to do well if you identify patients in that group and tell them they don't have advanced fibrosis. They probably have problems that would come higher on their list than NASH. On the other hand, if you have both significant fibrosis, here 9.6, just so you know, in our algorithm in our clinic, we use 10 as a cutoff. That's the stage 2, 3. So the problem with FibroScan is that you read 10 different studies and there's 10 different cutoffs. So you have to sort of avoid specific numbers and just say, what do I think this patient has? But nonetheless, in this study, 9.6 was used as a cutoff, and a high NAFLD fibrosis score cutoff, if you achieve both of those, then the positive predictive value for advanced fibrosis was 100%. Now, obviously, this is one study. I'm sure there are other studies where it wouldn't be 100%, but it's very high, and you can be very concerned that the patient has advanced fibrosis or cirrhosis, and then I would use that clinically to say, this is a candidate for a clinical trial. This is someone who may need HCC surveillance. If there were further questions, you could biopsy them, but these patients often don't need a biopsy. The problem is most patients are in the middle, and that still leaves you with many, many patients who are indeterminate for both tests, or maybe they're 9.5, 9.2, something for their FibroScan. And the question is, what do you do? Well, a biopsy in that situation is one of the only things you can do to be more sure. But what I do instead is I say, how is a biopsy going to change management? You can't biopsy 12 million people. There are complication rates that we have to, have to be sort of, we have to think about who we're going to biopsy. So if it's going to change what they do, if you think they have cirrhosis, you're going to do HCC surveillance based on the biopsy, or they'll enter a clinical trial based on the biopsy, then I would strongly encourage a patient to have the biopsy. But if they say, and they do, doctor, you told me to lose 7% of my body weight, is that going to change after a biopsy? I'm going to say, no, you should lose 7%. And often that's how our visits end, and I see them in follow-up. So here's another example of a case. This is a 59-year-old Caucasian man, overweight, pre-diabetes, high triglycerides, so metabolic syndrome. 14 drinks a week. I haven't mentioned it. For our research studies, and I think with good clinical correlate, we use 21 drinks a week for a man. Above that, it's probably alcoholic liver disease. And 14 drinks a week for a woman. Above that, it's probably alcoholic liver disease. There are some, just so you know, there are some studies that use 14 for men and 7 for women. And so there's a little inconsistency there. Certainly if a man's drinking 20 drinks a week, I'd probably mention something to them about, do you think you should cut back a little bit? But they would actually get into our fatty liver trials. And so that's the cutoff. The ALT in this patient is elevated, less than 2 times the upper limit of normal. The other numbers look fine. The ferritin's high. This patient was referred to me for an assessment of hemochromatosis, but a ferritin above 400 is a predictor of NASH. So this patient had a negative HFE gene mutation test and, in fact, just had NASH. Fatty liver on ultrasound, NFS. If I put the scale in there, no one should ever memorize this scale. There's more important things to use your brain cells for. But you can see that it's indeterminate. And then the FibroScan was stage 2. So this is the one in the middle. What do you do with this? Well, there's some concern. He's got the risk factors. The tests aren't normal. So you would have a conversation about this patient. Are you interested in a clinical trial? I have had one patient say, I just want to know. So we did a liver biopsy, and there's no problem with that. But we wouldn't push a patient like this to a biopsy because we don't have much that we would do differently. So here's my recommendation for this patient. If it's a primary care patient or an endocrinology patient, this is a patient I'd like to see. I think there's a chance they have NASH with fibrosis. They definitely need the lifestyle modifications. They could have a biopsy. You could consider vitamin E. It's the only drug that's ever been shown to be helpful for NASH, although it was not studied in diabetics. And this is a patient who would likely be a candidate for a clinical trial. And we have those. And for those of you who got a newsletter, I'll just say it now, we have 2 phase 3 and 1 phase 2 studies all open and enrolling. So spread the word if people might be interested. So this is what I'm the most excited about talking about. We got the CAP function on our FibroScan, 6 weeks ago? Something like that. So in transient elastography, which is FibroScan, the ultrasound wave changes frequency, which is then picked up as an elastic modulus, and that's the liver stiffness. So it speeds up through a dense medium, or it stays the same. We measure liver stiffness I've seen numbers in the 3s, and we've all seen numbers above 50. But, our interest lies between about 6 and 15, and that's where we're really trying to sort these patients out. But what we can also do with this ultrasound-based test is to measure the dampening of the amplitude or the attenuation of the sound wave. And it turns out there's not much that does that besides fat. And so that's measured in decibels per meter, and you end up getting scores between 100 and 400. I've never seen less than 100. I've never seen more than 400. And Jeff, I'll ask you if you have. Okay. So there have been a number of studies and 2 big meta-analyses that look at trying to set cutoffs, just like we set cutoffs in our clinic for stage 0 to 1, stage 2, stage 3, stage 4. The liver stiffness measurement was problematic enough already. You've got a few things that can throw you off by a point. You get variability in measurement. So we really have to be careful with the fibrosis score. And then I think we have to be careful with the fat measurement as well. If they have 2 O2s, is that grade 1 steatosis? I don't think the test is built for that. I think the test is built for saying this patient is very unlikely to have fat in the liver, or this patient clearly has some fat in the liver. The good news is S1, steatosis grade 1, S2, S3 has never been shown to affect progression of disease, progression of fibrosis, outcomes, cirrhosis, mortality, any of those things. It simply sets the stage for those things to happen in certain patients. What's interesting, though, is that this cap is as good as ultrasound at detecting fat. And so it sort of brings up the situation where you ask, well, why did a patient get an ultrasound? Well, in a lot of cases, the liver enzymes are elevated, you get an ultrasound. So if you were to ask someone, what were you looking for on that ultrasound? Well, you might be looking for dilated ducts, you might be looking for a gallstone, if they had pain maybe, or a story that fit. But if you ask people who are doing this, the answer is, oh, I thought it was fatty liver, so I got an ultrasound. And that happens a lot. And usually that's sort of a prerequisite for referral. So what we're looking at is to say, well, I'll get there in a second, is to say in these patients who have risk factors for fatty liver disease, metabolic syndrome, diabetes, elevated ALT, if you're just getting the ultrasound to show there's fat, then don't get the ultrasound. Get the FibroScan. It's just as good at answering that specific question. And it'll also tell you some very useful information about the likelihood of advanced fibrosis, or the likelihood that there's no fibrosis. I say it that way because there are patients who should have an ultrasound. And so there'll be times when either a primary doctor still should order an ultrasound, or where I may say, I got this referral, but it looks like the patient still needs an ultrasound. That absolutely could still happen. Let me go back and show you this study here. So this is getting at the point that diabetics can be hard to screen for NASH and NAFLD. So this is 103 patients, all of whom underwent proton-weighted MR spectroscopy to look for fatty liver. This turns out to be the most sensitive test for fat in the liver, probably better than biopsies, since you're getting the whole liver, and sampling error with a biopsy is up to 15%. So half of these patients had fat in the liver, and the key here is that the mean ALT was 23, and all of them were less than 40. So most of these patients would be missed. What was even more striking was that they convinced 37 patients, they offered a biopsy to everyone. They didn't twist any arms. So 37 of 103 said, sure, I'll undergo a biopsy. And of those, more than half had NASH. And so here is 21 of 37 patients with NASH, and the only thing here that would have tipped you off was just the diabetes. And so I'm actually not advocating all diabetics getting a FibroScan, but it has been done.
The BMI of 33.
Oh, right. So, and I actually showed you the slide earlier that obesity and diabetes together. Let me show you this case first. So this is a woman that I saw just a few weeks ago. I'm going to show you this because I think it demonstrates how the cap is useful. She's 59. She is overweight because the ideal BMI for her would be 23. She's diabetic, dyslipidemia, metabolic syndrome. ALT is 55. That for her is twice the upper limit of normal. Everything else is fine. No ultrasound was done. That's okay. She came and saw us anyway. And the question was NASH. And that was the referral. Is this NASH? And I'm encouraging people to send these patients, but I'm encouraging them to go directly to FibroScan because here's what it showed. It showed a cap value of 294. Now, whether that's S1, S2, or S3 could be, you don't know, but it doesn't matter. That's high enough that you say, okay, that's fat. That's fatty liver. And you look at her clinical history and you expect it anyway. But her FibroScan score is low enough to actually be very useful. The chance of this test or this patient having advanced fibrosis is very low. So low that we would, if it were hepatitis C, we'd discharge them from our practice. So if it were fatty liver, I would say, I actually saw this patient, but if I hadn't, I would say, do not refer. This patient does not have a liver disease that is really, the resources involved in having them come to our clinic, it's simply not worth it because her risk of morbidity and mortality from NASH is very low. Not so from her diabetes, but her endocrinologist can take care of her diabetes better than I can. So here's just to show that 5.4 is in the green, and we have a very similar chart that we use when we're reading these things. So if you start to think about this, you might say, what's an algorithm that you can use for screening for fatty liver? Again, screening for fatty liver has never been recommended by any large society because the cost of an ultrasound and the number of patients at risk is prohibitive. The cost of a fibroscan is still significant, but it's less than half of an ultrasound. So I think we're getting closer to being able to say, do we have a screening test? And if you say, well, maybe I won't screen 60 million people, maybe I'll just screen the X percentage of the population who's really at risk, and I think you have something that does finally make sense. The way this would work would be that you would set these cutoffs very conservatively. Less than 7, we're pretty confident these patients don't have significant fibrosis. Greater than 14, many of them, not all, many of them have significant fibrosis. Cap less than 200, by most of the studies I've seen, as there's no fat. Cap above 300, by almost all studies, there's fat. It doesn't have to be S3. I had to put my nickel down here, but you have to be careful when you do because, 13% of the patients in this box could have S2. And again, I think that would be okay if you were wrong on that one. So the idea is which box is the most useful? And I think the answer is the top row in the middle. These are patients who have fat. So if they're diabetic, overweight, and the ALT is high, they have fat, and they don't have fibrosis. You've diagnosed fatty liver disease, and you've shown they don't have risk of progression to cirrhosis. They don't need to come in. If you look at if you remember the slides I showed you, this is going to be 80% of patients with NAFLD. And so if they can do this test and sort of one and done, we can sort of develop a relationship with referring doctors, in particular to the endocrinologists, to allow them to interpret this, then I think we could really reach more patients. Again, why reach more patients? It's because 1 out of 100 patients with NAFLD has cirrhosis and 10 have fibrosis. You'll see that I put an asterisk here. The asterisk says, there's an asterisk in every single box. So when you're working up an elevated ALT, fatty liver is a diagnosis of exclusion, and it always will be. So the trick in this relationship between patients referred for fatty liver and then the answer that we give the physicians is going to be who checked the smooth muscle antibody in the 39-year-old woman, or who checked the hep C antibody in the 70-year-old man, or who checked the iron studies in the second-generation Irish person with a ferritin of 800. So those things still have to be done, and I think it will remain our job to ensure that when we're in contact with a patient or their doctor that we recommend these things be done, because they are still recommended. Questions? Yeah.
In regards to the Filipino woman, as she continues her life with diabetes and let's say it gets out of control, does that change her scores?
It does, and I would say to her, it looks like your other, often this is the case, it looks like your other doctors are checking your labs, like they're getting them every 3 to 6 months. So I don't give her a lab slip. I say, keep an eye on your liver tests, manage your diabetes. You're good for a couple years with regard to your liver. It won't change that fast. But there's no free pass based on that test. I say, I think it'd be reasonable to reevaluate you in a few years. And that goes beyond what our clinic can schedule, so I release them. But I do say there's still risk, and your risk can change. And so, yeah, if things change, come back by all means. And that's how I phrase it. It puts the responsibility back on the patient and the referring physician, but I think that's where it should be, because we can't watch these patients at low risk. There's just too many of them. Does that answer your question, Mary?
Yes. Do you send them the letter, the primary care physician, the letter?
If it's a direct referral for FibroScan, we updated the letter. If it's a consult, then the primary care physician absolutely gets a letter with a long explanation of all these things. The patient's supposed to get it, and we try to help the patient get it. Sometimes it's hard for the patient to get it.
I think you're too nice.
Well,
No,
it's a good point.
You give them an excuse for going on, continuing to do what
Yeah.
they've been doing
So
all along, which is the wrong thing.
You have to phrase it carefully. You don't want to give them a free pass, but at the same time, you can't take those patients on in the liver clinic or in your office because,
No, of course.
yeah. So you have to ride the line for sure.
But you have to explain to them the reason you're doing this investigation is because things are not
Yeah.
normal.
So-
and this is bad news for them.
So I talk about risk of cardiovascular
Serious or not
disease. We talk about risk of obesity. I talk about all those things with them, but in the end, the reassurance is really for their referring doctor to say, okay, well, it's useful to know this. I think it is useful. Kids.
I was going to ask, have you used MRE and, cystic fibrosis or fat in data like this?
Yeah.
Some data on 3D MRE?
I don't know the
NASH?
3D actually. I have, and I do. It's just not as accessible enough to really reach the numbers. I get it all the time. Almost every time I get an MRI on a patient, I'll get an MRE and I'll look for fat at the same time. And I had the quadruple the other day. I had iron, fat, lesions, and stiffness.
I wonder how that compares with FibroScan.
MR is better for detecting fat, and MR is better than FibroScan for the error into the receiver operated curve for fibrosis stage 3 or 4 is like 0.93 for MRE. It's like 0.8 for no, it's a little higher, 0.8 something. So it's better, but it's 10 times the cost, and not just the cost. It's hard. It's logistically difficult. So again, the thing that's exciting about this is that it's you don't even have to see the doctor, and it's sort of it's more accessible than we've been. Again, it's not perfect. The most accessible thing is the app, but and that'll be helpful in some cases. That'll be very helpful. You can say some patients are at low risk. So I use it, but I don't push the MRE because I don't think we're going to reach the patients that we need to reach with MRE. Assad?
There's a lot of weight being put on macrosteatosis versus microsteatosis. And, we evaluate a lot of donors.
Yeah.
And most of our donors, they're in their 60s, diabetes, hypertension, BMI more than 28, and then we go and do a biopsy, and you find there's 60% micro, and we ignore that, almost ignore that, but then macro, we put a lot of weight on it.
Yeah.
And a very good number of these livers, we bring them in, and we transplant them, and they do well. What is this going to fit? How are we going to evaluate that specific area of steatosis?
I don't think, you mean micro versus macro with this machine? I don't think it does.
No, in general, is macro bad? Really, we don't know. I mean, we just assume that this is bad.
Well, what I can say is that it's not bad. It never led to any increase in risk for any of the outcomes that we care about. But in the surgical setting, I think it's a little different. For example, if you have 60% fat, I can tell you that your risk of death from that fat is not increased. But that doesn't count for someone who's undergoing a partial hepatectomy with that fat. How do they respond to the stress of that is different. And so fat is significant in that situation. And that's where the donor liver comes in. It's a different story. Fat, I think, does matter. You know that better than I do.
Can have a role in evaluating donor liver?
Well, Harish asked me, I sent him there's an abstract. There's going to be a lot of abstracts on this. It's not just FibroScan, but CAP with this, right? The quantification of fat. It's being tried. But the trick is, how much do you care about a specific threshold, and how confident are you the patient didn't cross that based on this test? I think you have to be careful there, because I'm telling you, you can't be that confident that they're not 50 as opposed to 40. I don't think this test can tell you that. The thing with liver stiffness is that there are a lot of things that change liver stiffness. Scar, inflammation, congestion, obesity. And so it turns out that the CAP is actually independent of all those things. So the steatosis assessment is pretty good. It's pretty reliable. It varies. But the fibrosis assessment, you have to be careful. I scanned someone who had some heart failure once, and the score was like 70, like the highest I'd ever seen. She doesn't have cirrhosis. It was the heart failure. And these patients obviously are going to have that. So I would be a little cautious. Let me just go through a couple slides here. So in Europe and Asia, CAP has been around for at least 2 years. So this study's been done. And as with many studies that are out of Hong Kong or other parts of China, the study's been done with thousands of patients. So almost 2,000 patients with diabetes were screened with FibroScan with CAP. They weeded out the ones where the test was technically insufficient, and they still got a very high success rate there with FibroScan. So 73% had what they considered to be fatty liver. They set 222. That was arrived at statistically. There's no cutoff that everyone accepts for this. And almost 20% of diabetics had increased liver stiffness. This is consistent with what I've shown you. Here's the kicker, though. Those with fatty liver, 20% of them had increased liver stiffness. That's similar to this. And in those who did not have fat, only 7%. So you're seeing, obviously, a correlation between fat and liver stiffness. And it's based on the fact that they have NAFLD and NASH. But the thing that might have been the most useful about this paper was that the sensitivity was 94%. In other words, sensitivity rules things out. Was this test useful at saying so-and-so does not have stiffness? And it was. 94% is very high. Specificity not as good. Positive predictive value not as good. Negative predictive value very good. Some of the graphics from this paper suggested that, as you might expect, with more body weight, there's more fat in the liver. And with more body weight, there's more scarring or at least liver stiffness. Again, not surprising, but nicely shown. And then the other thing I'll show here is, so 94 of those patients had a biopsy, and they were able to correlate histologic findings using the Brunt criteria or the NASH CRN criteria. That's steatosis, inflammation, ballooning, and fibrosis, versus CAP and liver stiffness scores. So two things stand out here. One is that inflammation does seem to correlate with CAP, but ballooning does not. Now, ballooning is the thing that matters in NASH. Ballooning is probably the most important component in NASH. It does predict fibrosis and outcomes. Steatosis does not. The other thing that's interesting here is that not only did liver stiffness predict scarring, which is what it's supposed to do, but it correlated quite nicely with ballooning. And so I think it just gives a little more strength to what some people have proposed, which is using these liver stiffness tests, including MRE, for NASH and not just for scarring. Again, that was beyond the scope of this study, but you can see that NASH does seem to correlate, at least through ballooning, with liver stiffness. These next three slides talk about obeticholic acid, elafibranor, and an acetyl-CoA carboxylase inhibitor phase 2 trial. They're in the handouts, and I think I'm out of time, so I will skip those unless anyone had any specific questions about clinical trials. And say that I still would recommend that patients with a high ALT and metabolic syndrome, someone think about whether they could have fatty liver disease, and that we now have a tool with CAP that might allow us to not just estimate or give an opinion, but to actually measure their steatosis, fibrosis, and give them an actual clinically useful piece of advice. And that's my last slide. Thank you.